Good afternoon. This is Erin with the Department of Medicaid. It's not quite 2 o'clock and we're still clearing the waiting room, so we'll give it just a few moments before we get started. Good afternoon, everyone. It's now 2 o'clock and the waiting room is cleared, so I will turn it over to the TAC. It does look like you have a quorum. I show 4 out of 5 members.
Good afternoon. I know you guys are used to seeing Dr. Bobrowski, but since he made his exit, I will be the new chair, Dr. Millay. If any few of you know me, a few of you do not, it's nice to be on here. And forgive me as we go. I'm new to this, so we don't have the great experience Dr. Bobrowski brought to our meeting anymore. So bear with me on that. Give me some grace, please. Just like to welcome everyone to the TAC committee today. Can we have a roll call, please, Ms. Vickers? I guess you would be best at doing that.
I can, or the TAC members can introduce herself, whichever is preferable to you.
Okay. TAC members, can you introduce yourself? I know I had seen Dr. Kalasa, I know will not be on the meeting. He had texted me earlier due to a last minute conflict. So unless he gets done early. So once again, I'm Dr. Robert Millay, BJ Millay, present.
Dr. Carol Braun, present.
Dr. Caitlin Patel, present.
And I believe I saw Dr. Petrie on there somewhere.
I see him, but he might not. He is muted if he's talking. Maybe he stepped away briefly. I do show him logged in.
Okay, I was going to say on my screen, I had just lost his name. But I did see Dr. Petrie here. So welcome. Just one thing I was wanting to address, the individuals who are on the Zoom. I know it's a lot different than the old face-to-face meetings. There's many people on here, and we have several new TAC members. So if it was any way possible, I had talked to several of the TAC members to see if the people who are recurring members to these are recurring people on these calls, if they could email the TAC members so they knew who was kind of on the call as representatives for companies and things like that, if they would care to do that, just so we have an idea of who we are talking to at times, that are representatives for those companies, if that is a possibility. I did get the TAC members' email addresses, so those could be given out with their approvals. And I will go through those real quick. Dr. Robert Millay, my email is Millay, Millay, at smilesouthky.com. Dr. Carol Braun, email CJ Braun, CJBRAUNDDS84 @gmail.com. Dr. Joe Petrie, JSPetrey, JSPETREY @gmail.com. Dr. Justin Kalasa, JUSTIN.KOLASA @gmail.com. And Dr. Caitlin Patel, KAITLYN @KentuckyFamilyDentistry.com. Kentucky Family Dentistry is one word. First duty of the TAC would be to approve last meeting's minutes. Hopefully everyone had a chance to review those. I did ask for 2 amendments to be made that I did notice on page 2 as TAC members listed, to add Dr. Caitlin Patel to the TAC member list, as she was not noted on the original TAC member list on page 2. And by my name, it said not present, and I was in attendance. I had some internet issues getting on a little late. So if that not present could be removed and be added to that I was there. Do I have a motion to accept minutes based on with those amendments?
I'll make that motion.
Okay. Dr. Patel made a motion to accept those amendments and minutes. Do I have a second?
I'll second.
We have a second from Dr. Braun. So I call to vote. Please vote yes if you agree to accept the minutes as presented with those amendments.
Yes.
Yes.
Dr. Braun, can you please turn your camera on for voting purposes?
Yes.
Thank you. And then you can turn it back off.
There we go. Yes.
Dr. Braun, yes. Dr. Petrie, I think you might be on mute.
Yes.
Yes. And Dr. Patel, I believe you said had signified yes. Yes. Any opposed? Hearing none opposed, I move to accept those minutes from last meeting with those amendments made. At this time, I like to move things quick. But at this time, I would like to give the representatives of any company a chance to have an open floor to address the TAC committee. Just please identify yourself as you do so and be recognized by the chair. Do we have anyone wanting to address an open floor? I think I heard somebody.
I'll raise my hand. There we go.
Okay, there we go. Yeah, yes, Mr. Jonathan Scott.
Yes, I'm Jonathan Scott. I'm with DMS. I do have a presentation at some point. I don't know if this is the best time for that, but we could also do it a little bit later. But I did want to get on your radar. I have a presentation about a restructuring that we're doing of the Medicaid Advisory Committee framework after some federal rules have been proposed. This may not be the best time for that. I didn't know the direction you wanted to go on. Just wanted to get on your radar to do that at some point.
All right, thank you very much. If we can present that in new business, that might be a good option, if that is okay with you.
That sounds good.
All right, thank you so much, sir. Any other comments or questions at this time? Seeing none, I moving into old business. Any old business that needs to be addressed? I don't have any listed, so if no other TAC members have anything listed, I move that we move to new business. New business on the agenda. I believe you all have access to that. And just to make sure mine is in order. There was several questions, and I know several regarding medical loss ratios. And a lot of the questions often involved. We do know there is some MLR based within the Medicaid contracts, from my understanding, and there was questions involved with, I believe, how that was administered, and this is kind of a broad topic, how that was administered by the state, managed kind of guidelines set, and what those MLRs are exactly. As new members, I think there's a lot of questions in how those apply. Do we have anybody on the committees or in this meeting that might be able to address that? Because I know do we have what the MLRs for the MCOs are? Does anyone know?
Dr. Millay, this is Stuart Owen with WellCare.
Yes.
I can tell you that we're the threshold for us is 90% MLR
Okay.
for the MCOs.
Okay. Thank you very much.
Sure.
Yeah. And those are some of the things. Once again, like I said, several of us are new to that. So we are trying to learn that process a little bit more. So with a threshold of 90%, and this may be a state, how is that judged and recorded or reported to the state?
This is Angie Parker with the Department for Medicaid Services, and
Yes.
I am not the expert in this. Our finance department is,
Okay.
but we do contract with an actuary who helps. They get information, the encounter data from all the MCOs, and they do their actuarial magic, and that's how we determine what the MLR is. There
Okay.
is a portion in the managed care contract that discusses all the medical loss ratio information and how that works with the managed care. The managed care contract is on our website, and that's probably the best way if you wanted to review that prior to the next meeting for specific questions, and then we can make sure that we
Perfect.
get the experts on the line for you.
Okay, perfect. And that would be on the website, you said.
Yes, I'll put a link to it in the chat for you.
All right, thank you so much.
And Aaron can also provide that to you as well.
Okay,
Dr.
perfect.
Millay, just for your
Yeah.
information, I always send a follow-up email with any information from the chat, presentation shared, or links that are provided via the meeting. So
Oh,
I
right.
always try to follow up with all that information for you guys.
Thank you very much. Because
You're welcome.
That is being new to this. We are going to be, several of us have some questions on different aspects, and they're probably quite broad initially. Getting that information will help fine tune those.
Justin Derringer has his hand raised.
Yes, Mr. Derringer.
Thank you. Yeah, hi, my name is Justin Derringer. I'm the director for the Division of Healthcare Policy. And so I wanted to let you know, I appreciate your questions. Unfortunately, we don't have anybody, doesn't look like, from the MCO branch or that division that administers those contracts on to go in depth on those contracts. However, those contracts are public. All that information is built into their contract, the exact percentage amount that they have to pay out for benefits only. Like Ms. Parker said, we have an actuary that goes through all that data, all the encounter data that they send us, which means each service that's performed. They take all of that out, look at it based on the payments they receive. But if you have any specific questions, if you'll put those together, Ms. Bickers does an amazing job of going through each individual question, sending those to the experts here in the Department for Medicaid Services, and whom oversees those programs, and they can give you very specific answers to those questions. We try to have everybody on the calls for you all on the text to answer any questions, but sometimes we can't always do that. So if you all, whatever specific questions you have after looking at the contract, put them together, send them to Ms. Bickers, and she'll make sure that we have answers for you all way before next meeting.
That'd be wonderful. Thank you very much, Mr. Derringer. Do we have any TAC members that would like to add anything to that, questions regarding MLR? If Ms. Bickers, I will get in touch with you and get that information from you so the TAC members can review it and formulate some more questions that may be set into those more direct questions for you. And I think the next one kind of is very similar in the value added benefits. Because very often, of course, there's very added benefits of different courses. I know I've dealt with filling out paperwork for gift cards for clients, and I've heard everything from iPads being given away. Is there any information that could be given regarding value added benefits?
Absolutely. This is
Thank
Angie
you,
Parker.
Ms. Parker.
This is Angie Parker again, Director of Quality and Population Health with the Department for Medicaid Services. And there is a specific link that I'm going to put in the chat. I mean, I can show it to you as well if you want me to.
That
Yeah.
is wonderful. Just put it in the chat and Ms. Bickers can transfer that. That would be great to save you on time.
I mean, I don't mind going through it. Now, you might want to, I might suggest for future meetings, if you want the MCOs to go over their value added benefits in this meeting, but that's obviously up to you.
I don't know if the TAC committee members, would you want to go over that right now, or would you asking as members?
Aaron, why don't you let me bring up what they're going to, what they're going to see online, and then go from there.
Okay.
You're now a co-host.
Thank you. I did put the link in there already. So this is the link. This is what is on the website, and it has each MCO and what their specific value added benefits are. It's broken down by value added benefit category as best as we can. Like, to your point, there are some that offer, looks like all of them offer smartphones. There are certain maternal health benefits. There are rewards up to a certain amount of money for doing preventive services. Some offer home delivered meals. Now, this doesn't go into the specifics on, this is very high level, and they would have to contact the MCO on how to obtain these specific benefits.
Okay. And I think that is often what many members are, or what many dentists, when I hear talking about, one of the things they mention.
But that's what you would see as far as the link. And excuse me, I want to get real fast up to the top, but it does say for the details, it does have the ability to go in and check the details.
Each MCO.
Uh-huh.
Okay, perfect.
Okay.
Malaya, if I may, just kind of connecting dots back to previous meetings, and a lot of the questions on value added benefit were important with some of what Dr. Borowski was working towards, information he was looking for. And I think it all ties in with a question of, one, we're trying to have an understanding of these value added benefits, but also looking at aspects such as DLR, MLR. Are the value added benefits are they an aspect of that 90% of the MLR, or are they in the 10% other category?
They are part of the MLR. If it's relative to quality initiatives. There are certain CFR federal rules as it regards to MLR. So it depends on the actual benefit and if it falls within the parameters of the federal regulation.
I think from an optics point of view, from providers that are struggling obviously with fee structure and being able to not grow the program, which is what we'd hope to do, but at least keep it from dwindling as it seems to be. When we're dealing with a constrained fee structure, but we hear things such as the MLR at 90%, you think, gosh, well, that's a good ratio. But I think what Garth was really looking at was what are the other things that are that 90% being spent on that are not finding their way to patient care and to help increase our provider network.
I understand the question. And you'd have to look at each value added benefit to discern. For example, you brought up the smartphones. There are eligibility requirements. Each MCO would have to speak to that, but I'm just using that as an example. That's something in order to be able for that. If they didn't have access to a phone, they are able to provide those to assist in getting doctor's appointments or being able to call the pharmacy if they did not have that benefit or did not have that service already. So they wouldn't be giving phones to people who already had phones.
Well, I think we certainly all are for and behind improving access to care. I think the question becomes where the best resource allocation is to improve that access to care. And that's the bigger question. And that I think is where Garth was really looking at value added benefit in previous meetings and these questions that have arisen associated with the MLR.
Any other comments? Open the floor. If there's no other questions, on the point of care testing, I know that was going to be addressed by Dr. Kalasa, who is not here. I was going to table that until next meeting, and potentially some of the codes that we had discussed adding regarding intrasocket dressings, other types of scenarios that he had brought up that were concerns on the oral surgery side they were dealing with. As always, several of the MCOs had made great strides in decreasing the administrative burdens. However, there are still administrative burdens. I know I'm going through one right now with owed Medicaid. I guess we often call it state Medicaid, and the revalidation, and continuing to receive letters regarding revalidation. And my revalidation is almost 45, 50 days old at this point, and I'm receiving letters saying that my thing will be ceased and it's still in review. So I had to send out emails today regarding. So I think one thing with a lot of the portals, it seems like timing of getting things is often an issue on that part, without any answers and continuing to receive letters, constantly checking. I know I had talked to Dr. Bobrowski at one point, cumbersome applications on the revalidations, which have gotten, it does appear somewhat better in the sense being electronic, that information is often saved, but still going through those, it does take a lot of administrative time, and waiting for reviews back. And like I said, in my case, I know I'm continually receive letters and nothing I can do because my hands are tied while it's in maintenance for review. But credentialing, and I know I had talked to Dr. Bobrowski, and if anyone is interested, they can reach out to me regarding credentialing services. There is a new credentialing service that supposedly can drastically shrink credentialing. That will take for general insurances, Medicaids, federal, all kinds of aspects, from my understanding. And I can get more information for that if anyone is interested in that. But once again, does anybody else have any issues on administrative burdens? Because like I said, I know we are having portal revalidation with the partner portal, with revalidation issues and being constantly held on maintenance. The prior, and this is a question I would have directed, probably more directed towards a VSIS, if there isn't a VSIS representative on the line that might be able to clarify. On the pre-authorizations with a VSIS, there are often things that come up. I believe there's a code that comes up for, I guess, a reviewer. And it comes up saying it's denied, and then there might be a secondary code that, which the code you actually submitted, that says approved. But oftentimes the authorization comes back denied, saying when you initially look at it. Is there a way that can be modified, or is there another change that can be made? Because I know I've run into that, and I've heard other providers talk about that as well.
Hi, Dr. Millay. This is Kim Gray with Avisis. We have several representatives on the phone today. Is there a particular code that you're seeing the denial on?
I believe it appears to be, and I'm believing it is a reviewer, possibly, because it comes up in a different name. And I cannot remember the code number offhand, but then it says denied. And then I have like the code of what you actually submitted underneath there that might say approved.
Is it by any chance a D999?
Yes, I believe it is.
Okay. I believe that may be like a dental consultant code that may require signature. Is there anyone else on with Avisis that can explain this in more detail?
Hi, Kim. I had spoke with UM and they added the code, and it's basically where the dental consultant ties their signature to. I know they were talking about possibly doing it a different way, so you didn't see that rejected line, but it's just a way for whichever dental consultant is reviewing it, that their signature is basically tied to that authorization.
And I think that is throwing, I think at least our staff, and from what I hear, have been some others, when they initially look at it and see that rejected, they're
Right.
not going, it's rejected.
Yeah, I know.
And
I know there was talks about doing it a different way. I'm not sure where they are in the process of that, but we can definitely look into that for you.
okay, I appreciate it. Thank you.
You're welcome.
But has there been any other administrative burden aspects that people have had with any other things from pre-authorizations, credentialing? Once again, like I said, I know there were some things that Dr. Kalasa had also mentioned. With him not being on the call, we may end up tabling.
Dr. Millay, I can speak to the issue of pre-auths a little bit. We're also having a little trouble specifically with the VSIS end of it. Once we finally get a pre-auth approved, then we're submitting the claim with the pre-auth number attached, and we're still getting denied, and we're having to go through, and resubmit those claims 2 and 3 and 4 times to try to get that rectified. So I know that's something that we're facing. We're going through the trouble to get the pre-auth and have it approved. And we'll submit that pre-auth number with it. And we've even resorted back to mailing it a literal copy of the pre-auth approval with the claim, and still having trouble getting those rectified. This morning, my front desk and I spent approximately 1 hour in the portal just getting an appeal going, because by the time I filled out all the appeals
that is one I haven't had. I haven't run into in a while, but yes, I have had the session time, and I don't know if that is another one. I believe Miss Bloomer had mentioned, was talking earlier regarding that from Avisus, or regarding the pre-auth. That has been something with a session timer.
Yes, it's been added. So now you can just click extend. So don't
Okay.
panic, because that is like the best thing that's been added in my opinion, because you just click extend and you won't get logged out in the middle of a pre-auth or submitting a claim.
Yeah, I haven't had that happen in a while, but I have been beating the session timer, so I did not realize there was an extend button. So that is
Yeah.
good to know.
Yes.
And if there are any other examples that you would like us to look into in more detail, please forward those over to your provider relations representative.
Perfect.
And we'll take a look at those.
Perfect. Thank you so much. And that was
This is Kim Gray with Avisus.
Kim Gray with Avisus. Thank you, Ms. Gray.
Yep. Sure.
So specifics, please send over to the MCOs directly. And like I said, Dr. Colasa will, I'm sure, have some more things to address when he's on. The last thing we had in new business, if there was nobody else on that aspect, is the Medicaid findings that were presented in the Courier Journal article. And I know I did send a link out to Ms. Vickers and on that. The dealing with, and so much of it deals with access to care issues, from aging populations. I know we're always stating we have a adequate provider network. Of course, in the article, as they discussed, there's 5 counties with no dentist period in them. I've heard there's actually 2 more counties that have been added where a dentist has retired. So I've heard we are at 7. I can't verify that. And 45% of the providers are in essentially 2 counties with Fayette and Jefferson. And once again, if you add into the Northern Kentucky area, that probably encompasses a lot more of that bulk of the state. And we're seeing costly increase in aspects such as diabetes that are dental related. We're seeing relations and correlations with dentistry, and poor oral health, obesity, that greatly increase Medicaid's medical expense line. I believe so. The question is often dealing with how are we working as a state to try to increase the provider networks, especially in areas where there is a drastic shortage of providers. Has there been any, look, Mr. Derringer, I believe you came unmuted there.
Yes, sir. Thank you. I appreciate it. We are aware of that article. As you may or may not know, we are constantly assessing our provider network here in Medicaid. We're always trying to look for ways to expand our provider network. Dental providers are one of many providers that we have in the state right now where there is an access issue. So there's a lot of different reasons for that. One of the reasons is medical, in the medical community, clinicians are in shortage everywhere. It's not just in the limited to the dental field. It's everywhere. We see physician shortages. We see APRN shortages. We have optician shortages. We have them in each provider group. And so we're continuing to monitor that, study that, look at different ways that we can come up with increasing our provider network. We have a program. We have about a 5-page list currently of provider administrative easements where we've reduced provider burden, administrative burden in the past 3 years, things that we've removed. We've removed a lot of different prior authorizations to codes. We've removed over 200 prior authorizations to different codes in the last 2 to 3 years. We've expanded the codes that dentists in particular are allowed to bill by expanding that to the adult population, trying to extend the services that are allowed and the people that are covered by Medicaid services. As you all know, we now cover the adult population as well. And we were able to increase several fees for a lot of different codes. And in some cases, our dental fees are even more than private insurance. So we've tried to do those things with a very limited budget. Of course, as you all know, we have not did not get any increase in this last 2 years budget. And so we're hoping and waiting for the next budget to come. Maybe we will get an increase to be able to do look at those rates and do even more with those. But um, we're constantly monitoring that situation and looking for ways to add providers. But it is something that we are aware of, something that we're looking into. It is a progressing issue for not just dentists, but all providers. And so and it's not just limited to the state of Kentucky. It is a national, I don't know if it's a crisis yet, but it's something nationally that everybody is taking note of and talking about. In the CMS directors meetings, they're talking about provider shortages as well and access issues. And so we've done a lot of things to try to address that. As you all know, we have we started a no-show listing where we look at and encourage providers to enter any no-shows that they have. No call, no show in the billing system. We track those and it lists out, and we try to get a reason why they didn't show up, so that we can address those issues of why Medicaid providers aren't showing up. We recently started allowing for dentists as well as other provider types to bill for community health workers. Those community health workers do such things as work with members to make sure that they have transportation to their appointments, scheduling appointments in congruent with other appointments on the same day, making sure that they're reminded about their appointment times, make sure that they have their Medicaid coverage up to date, that they're not being disenrolled, those type things. All in a way to try to help the providers, to help our members first, and to have better quality care, but also help our providers to be more successful. So, kind of a multi-level approach of how we're trying to do that right now and addressing that in different ways. We still are monitoring this situation very closely and still trying to find ways to address this issue.
Any other questions that Mr. Derringer may be able to answer? Any questions regarding that article, as I know most dentists have seen and read that article. And I mean, as a, and I know as a provider that's in a heavy Medicaid populated area, the provider increase for those that do take Medicaid, it's a drastic. Losing the retiring providers has increased the load drastically on those that are remaining. And those that are remaining in the program are taking large hits, both in appointment times, in cost hits, as everything else keeps going up. That's just the bottom line. It's things are getting more expensive. So, Mr. Derringer, I appreciate your guys' work, and anything that you can contact us, anything we can do to help. I think most anybody member on this call would be happy to assist you guys in that. Once again, do we have any general, moving on, I believe Mr. Scott, this might be an optimal time for you to do your presentation, as it seems like the most questions of new business have ceased.
Very well. That sounds good. I'm going to share my screen here real quick. And hopefully, can you all see that? Sorry, not yet. Can you see it now?
I can see it, sir. I don't know about anyone else, but yes, I can see it.
All right, good deal. Well, we'll we'll go forth from there.
All right.
So we have recently started a general restructuring of our Medicaid Advisory Committee frameworks. So there's going to be basically three types of advisory committees that we work with. You all are a technical advisory committee, so you're not necessarily impacted by this, but some of your companion advisory committees are, which is why we're reaching out to all of the TACs and giving them this presentation as we start out. So we have a federal requirement to start a Medicaid Advisory Committee that already exists as the Advisory Council on Medical Assistance, which is also known as the MAC currently. There have been changes proposed at the federal level that become fully legal, become fully effective on July the 9th. So that is why we are moving forward and making some changes to our Advisory Council on Medical Assistance that will be incorporated into a new entity called the Medicaid Advisory Committee, also going to be called the MAC. So it's going to be easy for everybody to remember those terms. So still going to have the same advisory role. The biggest issues, or the biggest things to remember is the Commissioner of Medicaid will now be selecting the members. That's part of the federal law. The MCOs are going to have presence on there. There's going to be a rotating member on the Medicaid Advisory Committee. There will be a member from an MCO. They're going to be on there. So over the course of 5 or 6 years, each MCO will get the chance to serve for a year, to have a member serve for a year. And then the Beneficiary Advisory Council is the newest advisory council that's been created by the federal rule, and that we are going to be incorporating into our program going forward. So the Beneficiary Advisory Council is going to be groups. It's going to be individuals who are current former Medicaid beneficiaries, family members, or caregivers of Medicaid beneficiaries. And so as part of that, the MAC is going to have starting out 7 members who are also members of the Beneficiary Advisory Council. If the MAC grows, we also may see the number of participants from the back also increase, because there is a 25% of the MAC has to be comprised of Beneficiary Advisory Committee members. Gonna start out here talking about the Beneficiary Advisory Council. 15 members. We are in the process of getting applications and getting information about people who would like to serve. So if you know anyone who is a beneficiary, who is a parent, guardian, a caregiver, and who would be interested in serving on this, we are actively looking for folks. The window closes the 29th of this month, and we would love to have as many applications as we can get. So if anyone on the committee knows of anyone that might be interested, please reach out to them. We'd love to get their application and potentially get them on the back. So again, some of the folks from the back, there's going to be 7 of them who will also be part of the Medicaid Advisory Committee. And we're going to stagger their terms, starting out 2, 3, and 4 years. Eventually, once everything's going along like we hope, it'll be 4-year terms. People can't serve back-to-back terms, so we may try to find other ways to plug them into the advisory committees, into the TACs, and other ways to help do strategic planning in Medicaid during the time that they're off. So hopefully we'll have a solid group of folks who will be rotating on and off the MAC and TAC and back going forward. So there's a QR code here. that people can use. It'll take you to the back website. It's a way to find the application. Then after May 29th, there'll be a good way to find information about the back itself, about its meetings, about any initiatives they might be involved in. So let that sit there for a second, since it's got a QR code. All right, and then moving on, the Medicaid Advisory Committee is going to be a variation on a theme. It's going to be an advancement, a reimagining of the current Advisory Council on Medical Assistance. Dr. Millay, you may be a member of the MAC. I realize you are new to your position, so I don't know if you've participated in a MAC meeting yet, but the good news is, if you're a member of the current MAC and you've been appointed by your nominating body, you'll just continue forward on the MAC. There are a few members of the current MAC who are serving in an expired term, or we also have a couple of entities who have not nominated an individual to be on the MAC. So we're as part of this process, we're really reaching out, trying to make sure that folks know that they need to be reappointed if they're a current member, and they're also, if there's expired terms in play, we also may need to get their organization to help with getting them renominated. So the new MAC is going to be 31 members, so it's going to be a little bit bigger than it has been by a few members. Again, it's going to be that same staggered term structure just to start out. Then it'll be 4-year terms going forward, except for the MCOs, who will have a new member every year, just to give the different MCOs a chance to participate over the course of a few years. So that's all I have there.
Jonathan, if I may, I'd like to
Yes.
put in a plug that the Dental Association will also be gathering applications for their member for Dr. Orowski's term had expired. So they will be taking applications as well. Just throwing that plug in there for the Dental TAC members.
All right. So the Dental TAC is one of them that has a member who had an expired term. So we will need some help in getting folks nominated and getting that position filled as it starts back up. And to that end, this next page has a QR code that you can scan. We also have a website here, so our applications will be open. This could be significant for our Dental TAC members. And so I'll just leave that here. This is our last functional slide. The next one just says questions or comments. So since we could have some interest in this QR code and in this website, I'll just leave it open to hear and ask if you all have any questions as we are finishing up. All right, I will take that as. All right, has everyone seen all they want to see of this screen? All right, gonna give it 5 more seconds. All right, and I'm done. All right.
Thank you, Mr. Scott.
Thank you.
Okay. Is there any other discussion to be had in new business? Hearing none, move on. And is there anything that needs to be made as a MAC recommendation to come from this committee at this time? Hearing none from members. That is all I have for new business. I'll open the floor real quick for any kind of questions, comments that may be needed. Hearing none, that's all I have on the agenda as of right now. Like I said, apologize. This is my first meeting. Thank you all for giving me some grace in that. being new to the committee and chair. And I like to move things along quick. If there's no other comments, is there a motion for adjournment?
Make a motion to adjourn.
Dr. Petrie motions to adjourn. Do we have a second?
Second.
Second, Dr. Braun. I appreciate you all attending, and we will work toward our next meeting. Thank you.
Thank you. Have a good Friday, everybody.
Have a good day.